is Dr. Brower, who I mentioned earlier today is one of our true international experts who's going to talk about lung protective ventilation in ARDS. And we're very lucky to have Roy here. Roy is one of the true world experts because he's helped lead the ARDS network and what is now the PEDAL network, and is now truly the leader of that for the last year or two. But he's been at Johns Hopkins running their medical ICU and helping to really establish the best therapies for ARDS patients. So Roy, I welcome you to come tell us about lung protective ventilation.
Thanks very much, Greg, for inviting me to come back to Emory. It's always good to visit places, and this is one of my favorite places to visit. So the next 45 minutes or so, I'll talk fast because I don't want to cut into your lunch break. But we'll cover a fair amount of ground on this topic of lung protective ventilation in acute respiratory distress syndrome. I have no conflicts of interest in relation to the substance of this presentation. And here's a brief outline of what I'll try to cover. We'll spend a few minutes talking about the definition of ARDS because it seems to always have been problematic. Different people have different ideas about what ARDS really is. And then I'll cover these aspects of lung protective mechanical ventilation: volume and pressure during inspiration, PEEP during expiration, recruitment maneuvers, prone positioning, high frequency ventilation. And I'll end with some thoughts, data, and opinions on extracorporeal gas exchange. This is the title page from a paper that appeared in The Lancet in 1967. And this is widely considered to be the first description of the syndrome of acute respiratory distress in adults. These workers in Denver described a bunch of patients with different conditions, mainly sepsis and pneumonia, some with trauma. But they all had several characteristics in common. So different diseases, but a similar presentation, and hence a syndrome of acute respiratory distress. And the characteristics of the patients they described are listed here. They had what they described as diffuse infiltrates in both lung fields. They had cyanosis or hypoxemia relative to the fraction of inspired oxygen. They were not in heart failure, so the opacifications on the X-ray and the hypoxemia had to be explained in terms other than a hydrostatic edema. And they all had a condition known to predispose to inflammation in the lungs, such as pneumonia, trauma, and sepsis. Now, going back to cyanosis and hypoxemia, they didn't really give us exact numbers to say this is what you need to say the patient has hypoxemia. They just said hypoxemia or cyanosis. And likewise, they didn't really quantify how diffuse the opacifications had to be. They just said diffuse. And one person's diffuse is another person's not so much. So for a good while, for years, we kind of groped along. Everybody had different ideas about what ARDS really was. And we were in a condition like illustrated here in relation to the definition of pornography. And this is Potter Stewart. He was a Supreme Court justice, a notable justice for a number of decisions. This is the decision he gets remembered for, though. And this quote, you know, he was leading the majority opinion on whether this movie called The Lovers was pornographic. And in order to make that decision, he first had to define it, had to define pornography. And he commented that I can't define it, but I know it when I see it. And that's how we were in relation to ARDS until we started defining things. We would know it when we would see it, but each of us would know it in a different way. But by the way, I understand he had to watch the movie several times before he could make this decision. So nowadays we've defined ARDS back in the early 90s with what was known as the American European Consensus Conference definition. But there were some problems with that definition, especially with the use of the term acute lung injury, which some people thought was synonymous for ARDS, but it wasn't, and different people had different ideas what it really meant. So now we have what's known as the Berlin definition, which is, again, an American European Consensus Conference definition. Here's how we define it. It has to be acute in onset, less than 7 days since the onset of symptoms. Hypoxemia is defined as a PO2 divided by FiO2 ratio less than or equal to 300. There's an example of a P to F ratio. The opacifications must be bilateral, but not diffuse. They can be in as few as 2 quadrants on either side of the mediastinum. And you have to be confident that the opacifications are not due to something outside of the lung parenchyma, or that's not really a parenchymal infiltrate, such as atelectasis, a mass, and a fusion. The presentation must not be primarily from left atrial hypertension, which can be from a weak left ventricle, mitral stenosis, volume overload in a patient whose urine output is not sufficient. And there must be a predisposing condition. So there's our definition of ARDS. As I'm sure many of you, or perhaps all of you know, ARDS occurs when there's a lot of inflammation in the lungs. It causes increased vascular permeability that leads to edema. There's a decreased surfactant function because the cells in the lung that make surfactant, these type 2 pneumocytes, are injured. And then the edema fluid neutralizes the existing surfactant. When that happens, we get a lot of atelectasis, which contributes to shunt, which causes hypoxemia. There's high dead space. There's reduced lung compliance, increased work of breathing, and all of these things conspire to cause acute respiratory failure, so our patients get intubated. We estimate about 190,000 patients per year get ARDS in the United States, and about 70,000 of those patients die. And so there's a high morbidity and a high cost. Another way to look at these data is that 120,000 patients are surviving from ARDS. And in the last decade or so, we've come to realize that many of those patients continue to suffer with a number of sequelae, primarily neurocognitive and neuromuscular sequelae. So how do you manage ARDS? These patients are challenging, as you know. In fact, many patients with ARDS require all of your knowledge and sophistication in critical care. It's not just managing the lungs. Many patients with ARDS have failures in other organs and systems. But here's a summary of what I think is most important in most patients. Mechanical ventilation, judicious and timely use of antibiotics, judicious and timely use of fluids, diuretics, try to prevent complications, judicious use of sedation and analgesia, nutritional support, and physical medicine. So I'm going to focus now on this, mechanical ventilation, and we'll focus on this for the remainder of the presentation. We're pretty sure that when we intubate a patient whose breathing has failed from ARDS, that we're saving a life, or at least we're buying time in which we can stabilize the situation, pour some antibiotics in, buy time for natural healing processes to work. So we're pretty sure that mechanical ventilation gives a lot of patients a chance to survive. So going back to Ashbaugh and Petty's original report of the syndrome of acute respiratory distress in adults, in another report, also in 1967 in a different journal, they offered their thoughts about how to ventilate patients. And these were their thoughts. Traditional mechanical ventilation approach. I'm calling it traditional because we used their approach for many years. Tidal volume of 10 to 15 milliliters per kilogram, a generous tidal volume. That was good because these patients have high dead space. And without a generous tidal volume, carbon dioxide accumulates and then you get acidosis. But with a generous tidal volume and a relatively rapid rate, you can usually prevent hypercapnia. The generous tidal volume is also of some value in dealing with the problem of hypoxemia from shunt. Not great value, but of some value. They recommended using PEEPs of 5 to 12 centimeters of water because with those levels of PEEP, most patients could have adequate arterial oxygenation with a fraction of inspired oxygen that was less than or equal to 70%. And 70% was thought then, and still today, thought to be the threshold where oxygen toxicity occurs. I think it's much more complicated than that, but we're not going to digress there today. Suffice to say that these were their recommendations for generous tidal volume and moderate levels of PEEP. The problem with the generous tidal volume and the modest levels of PEEP approach is that we think it contributes to ventilator-induced lung injury. This CAT scan is useful to illustrate the two main forms of ventilator-induced lung injury that we think occurs. One form, which I call high-volume, high-pressure injury, occurs because we put a tidal volume in a relatively restricted, aerated lung. So we have aeration in a fraction of the original lung tissue in this patient with severe ARDS. Most of the lung tissue is consolidated, atelectatic, flooded. So we're dealing with only a fraction of the original aerated lung tissue. And if you put a generous tidal volume into this relatively small area of aerated lung, it'll stretch it. And stretching, too much stretching will cause ventilator-induced lung injury. Another form of ventilator-induced lung injury we think occurs when we allow lung volume and pressure to reduce to relatively low levels during exhalation. So I call it low volume, low pressure injury. We think the injury here is occurring at the margins between aerated and not aerated lung tissue. And we think one of the mechanisms of this happening is small bronchioles and alveoli snapping open and closing with every breath. They close with every breath because we're not applying enough PEEP to prevent them from closing. So low volume, low pressure injury from inadequate PEEP. So the generous tidal volume approach was probably contributing to ventilator-induced lung injury, and the modest levels of PEEP perhaps were not adequate to prevent or reduce the opening and closing injury. I like to use this colorful sketch of lung volume versus time in two breaths from a ventilator to illustrate those two forms of ventilator-induced lung injury. Overdistension from high volume and high pressure occurs here as lung volume increases into the pink and red zone, and lung injury from opening and closing occurs at these low levels of volume into the pink and red zone during exhalation. And we'll return to this sketch in order to better understand some of the interventions that we think are worthwhile. This is the title page from a report in 1998 in the New England by Marcelo Amato and colleagues, in which they report results of a small randomized clinical trial where some patients received a traditional mechanical ventilation strategy and some patients received a lung protective strategy. The traditional strategy is here with a tidal volume of 12 milliliters per kilogram and an average PEEP of 9 centimeters of water. In contrast, lower tidal volume, higher levels of PEEP, and recruitment maneuvers. And the survival curve strongly suggests that this comprehensive lung protective strategy was useful. So this was a notable report. It raised a lot of eyebrows for a number of reasons, one of which was that nobody before this thought that you could do clinical research in an ICU. Just a complicated environment where everybody has to be primarily concerned for patient outcomes. And science is just very hard to do in an ICU, but they did it. And another reason for eyebrows being raised is this substantial difference in the survival curves. A lot of people said, I don't think the way you use a ventilator is going to affect the important clinical outcome. It obviously did. There are a couple of problems with this report, one of which is that patients in the control group who received a traditional strategy. They died off relatively quickly, the first few days. And most people say, my patients don't die off like that. My patients on a traditional strategy. So there was concern that these patients were sicker than these. And maybe that's one of the reasons why the difference in the survival curves. Another concern is that we don't really know what worked. They did at least 3 things differently: a lower tidal volume, higher PEEP. The method for setting higher PEEP was controversial. They did recruitment maneuvers. There are a lot of skeptics about the value of recruitment maneuvers. So nobody was sure exactly what to do with this. But then this ARDS network did this randomized clinical trial of just lower tidal volumes, traditional versus lower tidal volumes. Going back to that colorful sketch, here's the control group. Here is the experimental group with a lower tidal volume. We're getting the peak of lung volume out of the pink and red zone, reduce overdistension injury. When we do this, of course, we're going to sacrifice something. Everything you do, you pay a price. What we're sacrificing is the benefit of the generous tidal volume in maintaining gas exchange, CO2 clearance, arterial oxygenation. So there's a potential benefit, but there's a price to pay. Those benefits and price to pay are summarized here. If you stick with the traditional tidal volume, you give higher priority to the traditional gas exchange goals and acid-base balance goals. You give lower priority to lung protection from overdistension injury. If you use the lower tidal volume approach, you just turn this table upside down. You give higher priority to this and priority to that. Before doing a randomized clinical trial, nobody really knew how to balance risks and benefits. Nobody knew if the price to pay was worth it. But this study strongly supported the use of the smaller tidal volume approach. It's summarized here in this mortality graph, a difference in mortality of about 9% between the 6 and 12 milliliters per kilogram study groups. Nowadays, some people question whether this was the right control group, but back in the early 90s and mid-90s when this study was designed, 12 milliliters per kilogram of predicted body weight was mainstream for what doctors were using. Some of you may remember a trial of a surfactant preparation called ExoSurf, also published in New England Journal shortly before this tidal volume trial. In that study, the tidal volumes that doctors prescribed were over 12 milliliters per kilogram on it. So this was mainstream before the results of the study were known. It was a complicated protocol with a lot of rules that controlled as much as we could so that we could isolate the effects of lower tidal volume. But this right here is the centerpiece of the protocol. And if you know nothing else about mechanical ventilation with lower tidal volumes, I think this is all you really need. You should aim for a tidal volume goal of 6 milliliters per kilogram predicted body weight. Predicted is based on gender and height. The formula for predicted body weight generally gives a lean body weight. As a point of reference, my predicted body weight is a few kilograms less than my actual. So I'm a little bit over the predicted body weight. So 6 milliliters per kilogram is the goal. And then if the plateau pressure exceeds 30 at 6 milliliters per kilogram, then reduce the tidal volume further to get the plateau below 30 and go to as low as 4 milliliters per kilogram. After doing this for 10 or 15 years, I found that in most patients, getting to 6 is easy. Some patients will get to Kipnick. Some patients will get mild to moderate hypercapnia, hypercarbia, a little bit of acidosis, but in most patients it's easy. Going to 5 and especially going to 4 is not as easy because the hypercarbia sometimes gets quite severe. But in approximately half of patients on the first day of mechanical ventilation, you can achieve this goal without going below 6. Now, some people have interpreted this to mean something different. And the interpretation goes like this: decrease the tidal volume until the plateau is below 30. Or if you're using pressure control ventilation, just set the pressure control level so that the pressure during inspiration is no higher than 30. So if you're on a PEEP of 10, give a pressure control of 18, then your pressure during inspiration will be 28. And that's almost the equivalent of a plateau pressure. So that's the interpretation. Now, this interpretation assumes that plateau pressure, getting below 30, is safe. Once you're below 30, you're home free. You don't have to worry about ventilator-induced lung injury and overdistension. So is that a good assumption? You might question, well, where'd you get 30? And it's interesting to think about where we got it. It comes from a few different thought processes, but suffice it to say, none of those processes were really very soundly based. I mean, one of those thought processes is, if you go to your total lung capacity, take a deep breath in until you can't get any more air in, your transpulmonary pressure will be 30. That's what happens in normal people. Transpulmonary pressure is the pressure on the inside minus the pleural pressure, which is on the outside. But we're not measuring pleural pressure. We're only measuring airway pressure. But that's one of the thoughts that got us to 30. 30 was a consensus among a bunch of people in the room at the time who said, I worry about pressures when they exceed such and such. It was just a consensus. So is 30 a safe upper limit for plateau pressure? So we've analyzed data a few different ways in order to answer this question. Is there a plateau pressure below which there is no benefit from reducing the tidal volume or inspiratory pressure? So if you have a patient whose tidal volume is 8 and the plateau pressure is 29, is that as good as a tidal volume of 6 with a plateau pressure of 25? Right? That's the key question. Is getting below 30, is that your goal? Or should you not accept just being below 30 as being as good as you can get it? So here is one analysis that addressed this question. It's a little complicated, but not too much. In that tidal volume trial, we have over 400 patients in each study group, traditional and lower tidal volume. And we divided each study group into quartiles after ranking them according to plateau pressure. So over here, we have the patients with the lowest plateau pressures, and over here is the patients with the highest plateau pressures. The yellow bars are the patients in the traditional group, white bars, the lower tidal volume group. So in this quartile, these are the patients with the highest plateau pressures. In fact, they're all above 37 in the traditional group. They're all above 29 in the lower group. I'm sure it doesn't surprise you that the mortality is lower here than here because these plateau pressures are high. There's a similar trend here with the plateau pressures in this bar here, which has 100 patients, in the range of 32 to 37, and in the white bar, it's in the range of 26. But notice that way over here, we have the same trend. So here's 100 patients whose plateau pressures on 12 milliliters per kilogram are 26 and below, right? Well under 30. Their counterparts in this bar have plateau pressures of 20 below, and their mortality rate is lower. So the same pattern in each of these groups. If you just look at all of these 400 patients represented here, we have 200 patients in the traditional group with plateau pressures of 31 and below. 31 is very close to 30. And the mortality rate of their counterparts who have the same disease, they just have different tidal volumes. Plateau pressures of their counterparts are lower and their mortality rates are lower. So we could not find an upper limit or a lower limit for plateau pressure below which there was no benefit to tidal volume reduction. So we reject this interpretation and maintain that your goal should be a tidal volume of 6, even if the plateau pressure is below 30 at a higher tidal volume. Your goal is 6. So lower tidal volume reduces ventilator-induced lung injury in the aerated regions, but what about the other form of ventilator-induced lung injury from low volume, low pressure, opening and closing 25 times per minute, over 1,000 times per hour, 30,000 times per day. What can we do to prevent that? Well, we can raise PEEP and keep some of those alveoli and small bronchioles from closing. So returning to our colorful sketch, we're going to raise PEEP and raise end expiratory lung volume to here at the same tidal volume, still using a tidal volume of 6. When we do this, the peak tidal volume starts reaching gently into the pink and red zone, so there's a price to pay. There's higher pressures and volumes during inspiration. But maybe by reducing all this opening and closing at the lower end, we can gain more than we lose. So there were 3 large randomized clinical trials of higher PEEP in ARDS. They're summarized on this slide. This is like a crude meta-analysis. ARDS network trial, the Canadian trial, the French trial. Higher PEEP arm, lower PEEP arm, mortality rates. Regardless of which row we look at, the differences in mortality are not impressive. In this case, it appears that higher PEEP was perhaps a little detrimental. In this case, and in this case, perhaps it was a little beneficial. Not significantly different in any of the studies. Even when we add it all up and take a weighted average of these mortality rates, weighted in terms of numbers of patients, we find a difference in mortality that favors higher PEEP by 2.3%. And even with 2,300 patients in the analysis, this is not statistically significant. So a lot of people were betting on higher PEEP. In fact, I think the enthusiasm for higher PEEP exceeded the enthusiasm for lower tidal volume. There's something about this mechanism of ventilator-induced lung injury that's captured a lot of imagination. So why did higher PEEP not work? Going back to the sketch we saw on the recent slide, one reason is, that I mentioned before, with higher PEEP, we have higher pressures and volumes during inspiration, and that was part of the price to pay. So maybe we had more over-distension injury that counteracted the beneficial effects of less low-volume, low-pressure injury. Another explanation is like this. We have 2 different patients with ARDS. Their CT scans look very different. ARDS is a syndrome, not a specific disease, and there are a lot of differences between patients, one of which is the pattern on their CT scans, another of which is their response to PEEP. Some patients are very PEEP responsive and some are not. Patients with this pattern, diffuse opacifications, they tend to be more PEEP responsive. I'm emphasizing tend because it's not a hard and fast rule. Patients like this, if you raise the pressure from 0 end expiratory pressure to 10 or 15 centimeters of water, they get a lot of recruitment and relatively little over distension. In contrast, there are these patients who don't respond well to PEEP. They tend to have these focal or lobar infiltrates, and when we raise PEEP here, we get a lot of over distension and relatively little recruitment. Now, we made no attempt to identify PEEP responders and enroll them in our clinical trials. We enrolled everybody because we didn't have a good feeling for the variability of PEEP responsiveness at the time that the trials were designed. And so some patients may have been enrolled like this and may have been harmed. Some patients who were good responders may have benefited. But when we calculate a single value for mortality in the higher PEEP group, it's affected by both those who might have been harmed and those who might have been helped. So that's, I think, the most popular explanation for why those higher PEEP studies came out negative the way they did. Again, it's because we didn't focus on patients more likely to respond to PEEP. So how to set PEEP? I think how to set PEEP is one of the holy grails in critical care medicine. We've been thinking about it for 30 years or so, and although maybe I think our thought processes are more sophisticated, we're still arguing about how to set PEEP, and nobody knows all the answers. Some people know none of the answers, but they keep talking anyway. So So how do you set PEEP? You could set it according to the oxygenation response, and for sure oxygenation response correlates with recruitment, but it's not a very tight correlation. You can correlate it with, you can set PEEP according to compliance. Raise PEEP until the compliance is maximal, and don't raise it any higher than that because the compliance falls off. I'll come back to this, by the way. Marcelo Amato recommended creating a pressure volume curve using a super syringe, slow inflation of the respiratory system. Create a pressure volume curve, identify what he called the lower inflection point, where a lot of recruitment occurs, and then set PEEP above that level. Some people say that CT scanning is the gold standard for identifying PEEP responders, but it's not very practical to just keep taking patients down to the CT scanner, especially if you think you should be doing this serially in the same patient. Stress index, impedance tomography, the FiO2 and PEEP tables, different ways of setting PEEP. So this article just came out a couple of weeks ago in the New England, driving pressure and survival in the acute respiratory distress syndrome. There's Marcelo Amato again, and he is the driving force behind this, so to speak. He's been thinking about this for a long time, and I think he led this group of investigators on a long exploration of ventilator and patient variables, trying to figure out what's most important with respect to how we set the so the co-authors here are leaders of previous clinical trials, such as the ARDS network trial of tidal volume and PEEP, and then the French group's trial of PEEP, higher PEEP, the Canadian group. So they're all the leaders of those trials who agreed to combine the individual patient-level data into one huge data set that Marcelo Amato constructed. And fortunately, in each of the clinical trials, very similar data were collected with respect to age, Apache scores, P to F ratios, mechanical ventilation variables, and so on. So with individual patient-level data, we could do what we call an individual patient-level meta-analysis. So we had 2,300 patients in this, I'm sorry, over 3,500 patients in this meta-analysis. So what is driving pressure? Here's a sketch of airway pressure versus time in a single breath in a patient on a ventilator. There's peak inspiratory pressure. There's the PEEP. If we hold the breath in for a half second or a second, the airway pressure falls to a plateau. And driving pressure is the difference between plateau pressure and PEEP. Basically, the driving pressure is how much does pressure go up during inspiration and come down during expiration. If we look at a sketch of airway pressure versus volume, higher airway pressure, higher volume, sigmoid shape, especially in patients with ARDS. Down here, where the slope is gradually increasing, the reason for that increasing slope is that as airway pressure and volume rise, some alveoli open, whereas down here at very low pressures and volumes, they're closed. And as they open, there's more aerated lung, therefore there's more compliance in the system. The slope of this curve at any point is compliant. So if you're using a volume-cycled ventilator, then here's the tidal volume, from here to here, and the resulting change in airway pressure is driving, delta P, driving. Incidentally, if you prefer to use a pressure-controlled mode, we can look at the exact same graph, but the dependent and independent variables become reversed. So in the volume-cycled mode, which I use almost all the time, I set the tidal volume so it's the independent variable, and what results in terms of the change in pressure is the dependent variable. If instead you prefer pressure control and you set the pressure control at, say, 15, then the resulting tidal volume is the dependent variable. But pressure and volume always go hand in hand. You can't tease them apart. So it's 6 of one and a half dozen of. So you can either set the tidal volume and get a driving pressure, or you can set a driving pressure and accept a tidal volume. So that's driving pressure on the pressure volume curves. This is a summary of the 9 clinical trials that went into the meta-analysis. You'll recognize some. Here is that study I showed at the beginning of Marcelo Amato's modest trial of a comprehensive protective ventilation strategy. Here's the ARDS network lower tidal volume, ARDS network PEEP, and then Mersat and Mead's higher PEEP trials. The last one is Dan Talmore's report in the New England Journal using esophageal manometry to guide PEEP settings. So one of the things that came out of this analysis, and the key thing that came out of the analysis, is that driving pressure is a very important variable. In fact, we should think hard about how to minimize the driving pressure. In this analysis, if driving pressure was known, then PEEP didn't predict anything. At a constant driving pressure, differences in PEEP didn't do anything on mortality. Same thing, at constant driving pressure, differences in plateau pressure, differences in tidal volume. None of these things made any difference at a constant driving. So I'm going to suggest that we should use driving pressure to set PEEP. And here's how to do it. We might walk in the room with the PEEP set here and with the plateau pressure here. And at this tidal volume of 6 milliliters per kilogram, the driving pressure might be 18. So for example, maybe the PEEP is 10 and the plateau pressure is 28. That's a driving pressure of 18. Now increase the PEEP a little bit, and now we have the same tidal volume, but a different driving pressure because we're working on a more compliant part of the pressure volume curve. Now the driving pressure is 14, down from 18. And if you raise the PEEP a little bit more, we'll be working on this part of the pressure volume curve where there's a lot of over-distension. Same tidal volume, but the driving pressure is back up to 18. So at a low PEEP, it's 18. At a moderate PEEP, it's 14. At a higher PEEP, it's 18. So in this patient, I would leave it at 14. Come back tonight or tomorrow and go through the exercise again. So driving pressure is easy to measure as long as your patient is not frantically trying to breathe, pushing and pulling. You don't need any special monitoring equipment because the ventilator tells you the pressures you need. It's okay to make inspiratory efforts, but it's not okay to be making expiratory efforts. The patient must be relaxed during expiration. If you measure the plateau pressures 3 or 4 times and you're getting replicable results, then there's a good chance your patient is relaxed. If, on the other hand, you're seeing crazy values up and down and there's no real true plateau, then the patient's probably trying to push out during exhalation, in which case you can't do this. So easy to do, no special monitoring equipment. Just make sure your patient is reasonably relaxed during exhalation. What about recruitment maneuvers? Returning to a pressure volume curve, here's a relatively low level of PEEP, and here's a tidal breath, inspiration, expiration. We're on this portion of the pressure volume curve where there's a lot of recruitment during inspiration and de-recruitment during expiration. We could raise PEEP and get away from that part of the pressure volume curve, but when we do that, now we have higher pressures during inspiration, and maybe it's not worth the price to pay. But if we do a recruitment maneuver, namely transiently raise the airway pressure to some high level that doesn't occur during tidal breathing, maybe 35 or 40 centimeters of water or higher, then some regions of the lung will open that are closed if you're breathing down here. In fact, some of them are still closed if you're breathing here. But if you recruit the lung and come back down, then you can set the PEEP here at the same level as it was here, but we have more aerated lung, more even distribution of the tidal volume, and probably a better, more lung protective strategy. So there are numerous ways to do a recruitment maneuver. One way is suggested here, where airway opening pressure here is raised to a high level, 35 or 40 centimeters of water for 30 or 40 seconds. During this time, lung volume continues to increase, telling you there's some recruitment going on. And then some patients will experience some physiologic improvements. Some patients will, some patients won't. In this study, there are responders and non-responders. Responders are identified because after the recruitment maneuver that occurs somewhere between here and here, the P to F ratios are better. And the elastance of the respiratory system is lower. That's like higher compliance. So these patients responded to the recruitment maneuver. These patients did not. Excuse me. Now, a notable thing here is first that only approximately half of patients respond, but perhaps more importantly, among the responders, the effect is gone within 20 minutes. So these are patients who are not paralyzed. They're making efforts. They're coughing. And within a short time, the physiologic benefit of the recruitment maneuver is lost. And I think that's fairly characteristic of recruitment maneuvers. The effects are variable. Some patients benefit, some don't. The effects are short-lived, unless you're going to paralyze your patient and prevent any muscular effort. And even then, in some patients, the effects are still short-lived. I use recruitment maneuvers occasionally when my patient has experienced a de-recruitment maneuver inadvertently. He becomes disconnected from the ventilator circuit, and his oxygenation is worse, and within 20 or 30 minutes, it's not back to where it was before. So in that patient, I may do a recruitment maneuver. And I do it very simply. I just raise the PEEP by about 10 or 15 centimeters of water for a minute, and then bring it back down to where it was before. What happened to high-frequency ventilation? At my place, we were studying it. We were enthusiastic. We were using it in 3 or 4 patients per month. But as we studied it, we noticed that we were paying a high price to do this. Well, one of the high prices is that the airway pressures were high. The mean airway pressures were frequently 30, 35 centimeters of water. That's high. And another problem was that we were giving a boatload of sedation to patients, ARDS, trying to make the patients relax and not fight the high-frequency machine. So now, in a couple of years ago, there are these 2 reports of the use of high-frequency ventilation in ARDS, and the results surprised most people. Going back to our colorful graph, the rationale here is ventilate the patient like this, with tiny tidal volumes at relatively high volumes, high mean lung volumes, high mean airway pressures. But avoid the pink and red zone up here and the pink and red zone down here. It made a lot of sense. I think it does make a lot of sense. The problem is that there's a high price to pay. Here are survival curves from the study done in the United Kingdom. Survival over time. There are 2 lines there, virtually concurrent. No difference in the survival experience. And the Canadians reported this survival experience in which the high-frequency group actually had a significantly worse survival experience than the control group. And this study actually was stopped early because it appears the high-frequency approach was. So, balancing risks and benefits. With high-frequency ventilation, you can use a very small tidal volume. With a very high rate, you can maintain adequate gas exchange. Makes a lot of sense. But like I've said a couple of times, we're paying a high price. High sedation, high airway pressures. The combination of high sedation and high airway pressures made some patients hypotensive, and then they got a lot of volume loading. The patients on high-frequency ventilation were more edematous. Their lungs were probably more edematous than the patients in the control group. And we think volume loading and edema is bad. So maybe that's why those studies came out the way they did. Prone positioning is trendy again because of this report in the New England Journal just less than 2 years ago. The rationale behind proning patients is illustrated in this CT scan. They're both of the same patient, supine position, prone position. my way of understanding the way proning works is to focus on the fact that the shape of the lung is not symmetrical from top to bottom. It's narrower here and wider here. So up here, because pleural pressure is more negative, this region of lung is open. Down here with higher pleural pressure, this region of lung is closed. If we go prone, the narrow region of lung is now at the bottom. It's closed, but we've gained more in the wider part of the lung, which is now superior. So we lose something in the ventral part of the lung, but we gain more in terms of aeration in the dorsal part of the lung. And oxygenation usually improves. And because we have more aerated lung, the tidal volume can be distributed more homogeneous. And that's lung protective. And these investigators in France showed us these survival curves, which are truly remarkable because of the magnitude of the effect. About 17% lower mortality in the group that got prone positioning. So it's a relatively large study. It's consistent with previous studies that were smaller and less convincing. Proning has become trendy again. We're doing it much more frequently in my ICU. In the past, we used high-frequency ventilation, but now we're doing proning. And this image is, I put this in to remind myself to say it's not as easy as it sounds like in the title of the paper, right? It's not rocket science. The problem with proning is to do it safely, you have to get about five people in the room who are busy and have other patient responsibilities. You have to get them 5 people in the room at the same time. And you have to have a protocol or a clear understanding about where are the risks and who's going to be assigned to prevent a problem. So the respiratory therapist keeps a hand on the ET tube. They usually assign me the Foley catheter. They don't trust me with anything else. But I always suit up to help. And because we do it more frequently now, we're more comfortable and it's just easier. So I'm going to finish with ECMO, and I'll try to go a little faster now, because I think a lot of you have worked with ECMO and know enough that I can go relatively quickly. Now, the rationale for using ECMO is a patient like this. That, believe it or not, that is the chest, although there's no air in it. So there's no gas exchange in this chest, so you need to do extra-corporeal gas exchange if you think this patient has a chance to make it. Buy some time for healing processes. So the ECMO circuit demonstrated here. Blood comes out of a vein, pump, ECMO gas exchange device, the membrane, gas flow, carbon dioxide moves this way, oxygen moves this way, blood moves back into another large vein. So it makes a lot of sense. You can maintain adequate gas exchange like this and buy time for healing. There were a couple of previous studies of ECMO, randomized clinical trials, reported first in 79 and then in 94. And the results of these trials were disappointing, and because of those trials, most people backed off of ECMO. But now in the last 5 or so years, there's a lot more interest. First, because the equipment is much better. Less anticoagulation, less fragmentation of red blood cells and platelets, and so on. And another reason for renewed interest is when H1N1 was coming. The Australians and New Zealanders reported their results of using ECMO in a bunch of patients with severe ARDS. And it was severe. P to F ratio is 56, relatively high PEEP. And they reported their mortality rate of this group of patients, uncontrolled. All of these patients got ECMO. Mortality rate is 25%. That's impressive. However, keep in mind that this was a young group of patients, 34 years old on average, compared to in the average age of the 50s, in the 50s in most randomized clinical trials. So they had very few comorbid conditions. So these were young people with single organ disease. And I love those patients. I have a low mortality rate in those patients without ECMO. I don't know if it's as low as 25%. They're severe, P-DEF ratio of 56. But this is not a convincing report to use ECMO. And there are secular trends in critical care. There are a lot of improvements. I've summarized some of them here, and you all are familiar with these. We don't have to spend a lot of time on this. Secular trends result in improved mortality. So you might be improved by 25% compared to what was reported years ago, but whether it was ECMO or something else that allowed that low mortality rate, nobody really knows. One of the things we know is that the more you do something, the better you generally get at it. So here's an odds ratio of death in the hospital among patients with acute respiratory failure. And then on the horizontal axis is annualized hospital volume. So high volume, low volume, and there's a clear relationship showing that the high volume hospitals have a lower mortality. And it's not because they have patients who are less sick. This is adjusted for severity. This has been demonstrated in other conditions like bypass graft surgery. Here's a report of a randomized clinical trial done in the United Kingdom of in patients with severe ARDS. They were randomized either to be transferred to a single tertiary care center in the UK where they could do ECMO and where they have a lot of experience managing ARDS. So randomized to the acute care, the tertiary center with the ECMO capability, or to stay at the home hospital. And the patients who go to the tertiary care center, they do better. Most of these patients did get ECMO, but not all of them. We also know that some aspects of care that we think affect mortality were different here than here. In fact, we know that tidal volumes were higher at the home hospitals than in the tertiary hospital. So I think this study demonstrates that if you have a life-threatening condition and it's complicated, it's better to go to a tertiary center where they have more experience. It does not demonstrate that ECMO is the key to success. At this point, one of my fellows usually pulls out this study about parachute use to prevent death and major trauma related to gravitational. Systematic review of randomized clinical trials. Every year the British Medical Journal around Christmas time publishes a funny article like this for fun. And in this systematic review, they find there are no randomized clinical trials. The basis for parachute use is purely observational. Most patients who come to Earth with a parachute do live. The apparent efficacy could be from a healthy cohort effect because, it's generally young, healthy people who parachute out of airplanes. Individuals who insist that all interventions need to be validated by a randomized trial need to come down to Earth with a bump. They're telling me that. That's me. So when do you need a randomized clinical trial? Sometimes. You can't do an RCT on everything that you wish you could. The resources just aren't there. And it's probably not worth the cost. But if there's equipoise in the community, there are proponents and skeptics. When the new intervention has risk, when the new intervention is costly, and the only way to get good cost-effectiveness data is in a randomized trial. And when the new intervention is intended to improve a clinical outcome such as mortality, and the reason for that bullet is that there are a lot of different things that can affect mortality, like tidal volume and the sophistication of the intensive care physicians in various other ways. And if you don't do an RCT, you'll never know whether it was a new intervention that was associated with lower mortality, but the reason was something. Okay, there's a long list of trials that we believed in but did not work. One of the earliest good examples is the use of flecainide to suppress arrhythmias after myocardial infarction. Here's a randomized clinical trial of patients after an MI who got either enconide or flecainide. It's very similar drugs, work the same way. These patients were supposed to do better, but they did worse than the placebo group. It definitely suppresses PVCs after an MI, but it promotes life-threatening dysrhythmias in other ways. So here's a partial list of trials that we believed in but did not work in critical care. They're surfactant for ARDS. intra-aortic balloon pump for cardiogenic shock. Cardiologists used this for 30 years before doing an RCT. Published in New England Journal, didn't make any difference. They still do it because they're pretty sure they know how to do it. High-frequency ventilation for ARDS. So how many times are we going to make that mistake of believing something works and not testing it? So I think ECMO needs to be tested in a rigorous fashion. There's sound physiologic rationale. The previous trials were disappointing, but the new technology is promising, and the recent uncontrolled case reports are promising. The CESAR trial is not compelling. That's the trial in the UK with a single tertiary medical center that received patients and maybe did ECMO. All those promising trials that didn't work, again, how many times can we make that mistake? We need a higher level of evidence and so that we can prove efficacy and cost effectiveness. Thank you very much.